So we're going to take a look at the excretory system here. Most books will look at this strictly in terms of the system that's going to produce urine for the body, but we're going to look at it in terms of the totality of the excretory system. So when we look at the excretory system, we have to look at what tissues, organs are going to be involved and what their overall function is going to be as it relates to homeostasis. In this, we have the renals in the skin, which will be removing any type of solid waste or metabolite in an aqueous solution. The liver is going to remove whatever the liver wants to remove. And so this is going to be solid waste, metabolites, toxins, anything that the hepatocytes or the Kupffer cells will go ahead and digest and metabolize. The lungs will be removing anything that is volatile, that is anything that can be removed as a gas, which will be any type of aerosolized metabolites or toxins. The principal toxin that we're going to be looking at coming out of the lungs will be carbon dioxide. When we look at the overall function of what's going on here, we have to delineate between two concepts here. What is a waste and what is a metabolite? So we'll see stuff in the excreted materials that are not wastes, even though we talk about it as being excrement. Wastes are things that cannot be used for any other metabolic process. And so these are things like urea, nitrated urea, uric acid, bilirubin, ROSs, reactive oxidative species, superoxides, bioactive or bioinactive toxins. These are metabolites that have been manipulated by either hepatocytes or by nephronic cells in terms of their chemical nature, or carbon dioxide. The other thing that we might see within the excrement is metabolites. And so metabolites are things that we can see in metabolic processes. They can be released either because they're in excess of homeostatic level or because they're needed in order to make the solution that is going to be within the excreted materials. So things like water, sodium, potassium, we'll see them in the excreted materials, but they're not excrement, they're not waste products. They're necessary in order to create the solution for the excreted materials. But we'll also see things like glucose and amino acids that are going to be in solutions. If we see glucose, amino acids, or ketones in solution, it's usually because they're in excess of homeostatic levels. When we look at what solutions are going to be excreted, the solutions that we're looking at in terms of excreted solutions include things like urine, sweat, bile, sebaceous secretions, as well as ventilatory gases will all be excreted solutions. So let's start off with the review of some of the anatomy that we've looked at previously, and then we'll look at it in terms of how it's going to function for the excretory system without getting into all the physiology of what's going on. So we'll start with the lungs and the alveoli. Remember that when we're looking at the alveoli is a cluster of simple squammal tissue that is surrounded by a highly vascularized network of capillaries. We'll see this kind of same situation here on all of the organs. We're going to get a large capillary network or a large amount of blood flow interacting with simple epithelial tissue, either squammal epithelial or cuboidal epithelial. And what we're attempting to do is we're attempting to increase the total surface area available and diminish the distance upon which diffusion has to take place so as to maximize the rate of diffusion and exchange. As we go deeper into the alveolus itself, we get into the alveolus where we're going to have the simple squammal epithelium in their sac-like structures with the capillary networks interspersed around the clustered spheres of the simple squammal epithelium. In this organization, what we're going to be able to do is we're able to have a diffusion current between the alveoli and the capillaries as blood flows through the capillaries from the pulmonary arterial to pulmonary capillary side out to the pulmonary venule side. When this happens, we start to exchange carbon dioxide levels. So on the pulmonary arterial flow side, going from the pulmonary artery to the pulmonary vein, we start off with a elevated carbon dioxide level at about 45 millimeters of mercury pressure. with elevated levels of carbonic acid and bicarbonate, because remember your blood is a carbonated solution. As it traverses through the capillary, what ends up happening is that we start to exchange the carbon dioxides until we eventually get to a net zero level on the venal side of the flow here. And it's going to diffuse so that we have a net movement of carbon dioxide out of the vasculature into the alveolus. So the next step we're going to look at here is we're going to look at the hepatic anatomy. And so when we look at the hepatic anatomy, it's two things that come into play here. The first one that comes into play is what's referred to as the first pass mechanism of hepatic function. And then we have to look at what's happening within the functional unit of the liver, the lobule. Overall function of the liver is based off of the first pass system, which originates due to the vascular flow into the liver, where all venal flow into the liver is going to come from the hepatic portal system. The confluences of the veins exiting the intestines that we've looked at so far, which includes the inferior and superior mesenterics and all of their branches, the splenic, as well as the right and left gastric veins, are all going to junction together, forming into the hepatic portal, which will then head into the liver itself and branch into the right and left hepatic branches. Within this, we have distinct areas of the liver that will be doing distinct functions, where we're going to have the left side of the liver going to be predominantly on the digestive end, and the right side going to be predominantly on the excretory side of function. Following the flow into the liver, we're going to have confluences branch apart from the hepatic portal into the individual lobules. So we're going to have these branches of the hepatic portal is going to match up with branches of the hepatic artery and head out towards the lobules. Coming away from the lobules, we're going to get the central veins of the lobules going to junction together to form the hepatic vein. It's this confluence of flow where the arteries and the veins are going to flow in the same direction, which establishes the mechanisms by which the lobules will function. And so the way in which the lobules function is by allowing for fluid flow through the lobule itself, starting from what's referred to as the portal triad, which is the junction of the branch of the hepatic portal with the branch of the hepatic artery and a collection duct of the hepatic bile duct. These form a ringed structure, and stemming from the vasculature, we get a network of canal that is referred to as the sinusoid. The sinusoids are going to flow from the triad to the central vein, and that central vein will then junction back into the hepatic veins and exit into the inferior vena cava. It's the flow through the sinusoids are going to be interacting with the various cells that we see within the liver. The principal cell that we're going to see within the liver are the hepatocytes, but there are other cells that are going to be involved with the function of the liver as it relates to excretory function. Coming away from the hepatocytes is a secondary set of canals known as the bile canicules, and they're going to form into the bile canal, which is going to form into the bile duct. The bile duct will then junction together with the hepatic ducts, forming the right and left hepatic duct, and will carry bile away from the liver into the duodenum via the common bile duct, like we looked at with the digestive pathway. In terms of the cells that we're going to look at within the lobules, we're going to have hepatocytes and we're going to have Kupffer cells. These are phagocytotic cells. The hepatocytes are fixed within the liver itself, within the lobule structures, whereas the Kupffer cells are going to be found within the actual sinusoid itself. They're going to be phagocytotically ingesting whatever they can phagocytotically ingest. The hepatocytes themselves are going to be biliated in terms of their structure. They're going to be ingesting materials and then biotransforming that material. Some of the biotransformation that the Kupffer cells will be doing is going to be in relation to the removal of things like ethanol, hemoglobin. They will also initiate uh, responses to distinct hormonal signals from TNF alpha, as well as induce responses by releasing some interleukins and some TNFs into the sinusoids based off of exposure to superoxides, or what's referred to as a lipopolysaccharide, or an LPS, which is an indication of infection or inflammation. The superoxides are going to come about because of excessive amounts of metabolism taking place within the Kupffer cell as well as within hepatocytes. The Kupffer cells and hepatocytes will be able to store materials. Some of this storage leads to issues, which we'll take a look at here in a second, that can develop into the liver diseases. One of the more prominent liver diseases will be cirrhosis. Along with the Kupffer cell and the hepatocytes, we get two other types of cells. We get the dendritic cell and the stellate cell. The dendritic cell and the stellate cell are immune cells that we see that are going to be between the slit and fenestrated membranes of the sinusoid and the actual hepatocyte themselves. They're going to initiate the immune response that we see within the liver to any type of disease or transformation. And so when we look at the way in which flow happens, and we'll see something very similar to this flow when we look at the renal functions here in a second, is that we always refer to as a countercurrent flow of fluids, which means that the blood is going to move in one direction from the triad to the central vein, whereas the bile is going to be moving in the opposite direction from the central vein towards the bile duct. And what this is going to allow to do is this is going to allow for diffusion of metabolites in opposing directions so that we're able to establish a net neutral balance of diffusion for materials that can diffuse across the membranes or that will be exocytotically released from either hepatocytes or from the Kupffer cells. Within this process, injuries and damages can occur. And one of the principal things that's going to cause injury or damage is excessive oxidative stress to the hepatocytes or excessive oxidative stress to the Kupffer cells. When hepatocytes and Kupffer cells are overactive, what ends up happening is they start to release activators. These activating cytokines, these activating hormones, they take the silented or the quiescent stellate cells and they activate the stellate cells. When the stellate cells become active, what ends up happening is that they induce a response that is very similar to a clot formation within the blood, but in this case here, it's going to be a clot formation within the sinusoid, what we refer to as a fibrotic change. It's taking a soluble protein and turning it into an insoluble protein. As this occurs, we start blocking flow through the sinusoid. The blocking of the flow through the sinusoid induces additional stress, which induces additional activation, which induces additional fibrosis. If enough of the sinusoid is blocked, the lobule will start to become damaged itself. Damage to the lobules leads to cirrhosis of the liver. Cirrhosis is a long-term duration event due to excessive stresses, particularly excessive oxidative stresses on the hepatocytes and on the Kupffer cells, inducing this fibrotic change within the sinusoids. Now, what is interesting within this pathway is that as injuries do occur within the hepatocytes, they can be replaced by other hepatocytes. Hepatocytes are constantly replicating themselves at very high intensities and very high durations. In fact, one of the things that can happen in terms of what we deem as a liver transplant is that part of that right liver section, the section that's involved with the excretory function, can go about and replicate itself back from the person who donated the part of the liver. And the part that gets donated can go ahead and replicate and replace the damaged areas that came about due to cirrhosis within the person who had the liver transplant.